So hi students, so here I am happy to see you all with a new video, which is a clinical case-based discussion video. It is on inborn error of carbohydrate metabolism, especially galactosemia. So the objective of this video will be, you'll be knowing about galactose metabolism, minor galactosemia, classical galactosemia. So all of the biochemical basis or features of classical galactosemia and minor galactosemia. Yes, along with few other questions. So this is going to be a clinical case-based discussion, so I'm not going to disappoint you. So please watch the entire video. It's going to be just few minutes. So here and there, you'll not find all of the points on this galactosemia in any single textbook. So here I am to help you with compiling all the points from different textbooks. All right. So let's get into the discussion. So let's start off with a clinical case. So a 4-month-old child was brought with a history of vomiting, feeding difficulties, and failure to thrive, along with developmental delay. So the child was born at full term by normal delivery. Birth weight was 3 kgs and exclusively breastfed. All right. Now the child also had suffered from severe and prolonged neonatal jaundice, and child now weighs 4 kgs. So on examination, he had hepatomegaly and bilateral cataract. So it's a 4-month-old child. So from it exclusively breastfed child, but still it developed a history of vomiting, feeding difficulties, failure to thrive, along with developmental delay. Yes, he has also suffered severe and prolonged neonatal jaundice. This is a prolonged neonatal jaundice along with hepatomegaly and bilateral cataract. So with hepatomegaly and bilateral cataract, you can easily come to a conclusion that it is galactosemia. Yes. So look at the split question. What is your diagnosis? What is the biochemical defect? What is the biochemical test for reducing sugars? What are the non-carbohydrate reducing substances in urine? And what is the treatment for this disease? So be it MBBS or any competitive exams. So this clinical case-based identifying case is a very favorite question for all. So with this, what can you find out? The diagnosis is classical galactosemia. Is it not? So let's start with understanding the galactose metabolism. So galactose from the diet. From your diet, how is it absorbed? Galactose from your diet is absorbed through a sodium-dependent glucose transporter. Now with this sodium-dependent co-transporter. So from this intestine, it is taken inside the blood via blood transporter. So various blood transporters will take up galactose inside the cells. Okay, so galactose as it enters the cell, what happens? We have to trap this galactose inside the cell as galactose phosphate along with phosphate. So we are going to trap this galactose inside the cell as galactose 1-phosphate. Okay, so by the enzyme galactokinase, So we are trapping this galactose as galactose 1-phosphate. Now this galactose 1-phosphate is converted to UDP galactose. Yes, converted to UDP galactose with the help of the enzyme galactose 1-phosphate uridyl transferase. Galactose 1-phosphate uridyl transferase. So using this enzyme, UDP galactose is formed. Now there is one more enzyme which is epimerase. Okay, epimerase which epimerizes UDP galactose to UDP glucose. So as long as there is glucose in your body, as long as you take adequate diet, glucose gets converted to UDP glucose. UDP glucose can form UDP galactose. So you need galactose for what? You need galactose for glycosaminoglycans, your keratin sulfate, okay, your sphingolipids, yes, your cerebrosides, glucose cerebrosides. Is it not? So these they form an integral part of your nerves. So these things are essential components which are derived from the UDP galactose. So as long as UDP glucose is there in the circulation, it can form UDP galactose. But if there is an enzyme deficiency, of galactose 1-phosphate uridyl transferase, along with the epimerase, then what will happen? Yes, you will definitely get the features of classical galactosemia. Is it not? So let's see how it is. So what is galactosemia? Minor galactosemia. What is minor galactosemia? It is the deficiency of galactokinase enzyme. It is a deficiency of galactokinase enzyme. So what is the function of galactokinase? Is to trap galactose as galactose 1-phosphate inside the cell. So if you do not trap galactose as galactose 1-phosphate inside the cell, what can happen? Galactose gets accumulated. So this galactose can easily go back into the circulation. So in the circulation, galactose gets accumulated. This is nothing but called your galactosemia. Yes. So this galactose and excess galactose in the circulation can enter even your lens fibers. In the lens fibers, what can happen? Excess galactose, yes, can get converted to dulcitol. Excess galactose can get converted to dulcitol by an enzyme aldose reductase. Yes, so dulcitol is osmotically active. Sorbitol, dulcitol, these are all osmotically active compounds. So they can absorb more of water content. So as it is osmotically active, yes, so leading on to swelling of your lens fibers, which is responsible for cataract formation. Okay, So now do you understand how you develop cataract in a galactosemic patient? Yes. So excess galactose in the lens fibers, galactose gets converted to dulcitol. The dulcitol is osmotically active, so it attracts water inside the lens fibers. The lens fibers swell and leading on to cataract. So in minor galactosemia, you don't find much of symptoms because you have the UDP glucose, which can get epimerized to UDP galactose, and UDP functions of UDP galactose can take place. So only cataract is the main manifestation in a minor galactosemia, galactokinase deficiency. Okay, now let's see about the major galactosemia, which is called the classical galactosemia. Now, classical galactosemia is due to deficiency of, what is its deficiency? It is due to deficiency of galactose 1-phosphate. Yes, galactose 1-phosphate uridyl transferase. Galactose 1-phosphate uridyl transferase. Okay, so what is this enzyme essential for? This enzyme is essential for conversion of galactose 1-phosphate to UDP galactose. Yes, galactose 1-phosphate to UDP galactose. So if this step is not taking place, there is deficiency of galactose 1-phosphate uridyl transferase. The UDP galactose is not formed. So galactose 1-phosphate gets accumulated, or your galactose itself gets accumulated as it inhibits the previous step also. Yes. So this galactose can enter into the circulation. Yes, this galactose, excess galactose enters into the circulation. So there is excess galactose in the circulation. So as we have seen in the previous case, the excess galactose in the lens fibers, what can happen? Lens fibers, it can form dulcitol. Dulcitol is osmotically active. It attracts water. There is swelling of lens fibers, which leads on to cataract. So that is why there is bilateral cataract in this patient. Okay, cataract is a predominant symptom here. Now, what are the biochemical basis of other features of classical galactosemia? Now that we know there is galactosemia, because there is excess galactose in the circulation, there is galactosemia. Then it leads on to the development of cataract. Now, what you should know, all of the galactose is accumulated as galactose 1-phosphate here. Yes, so this is a feedback mechanism. Excess galactose gets accumulated, but galactokinase enzyme is not deficient, is it not? So the galactose can get converted to galactose 1-phosphate, and galactose 1-phosphate gets accumulated here. So all of our phosphates are being utilized or being stuck in this step. Yes, so galactose 1 as well, galactose 1-phosphate. So there is decrease in, what? There is decrease in inorganic phosphate. Yes, there is decrease in inorganic phosphate. So this is nothing but hypophosphatemia. Yes, hypophosphatemia. So since all our phosphate is getting trapped as galactose 1-phosphate inside the cell, there is decrease in inorganic phosphate leading on to hypophosphatemia. Now, decreased inorganic phosphate. Why? Well, for which enzyme inorganic phosphate is very essential? Glycogen phosphorylase. Okay, glycogen phosphorylase needs inorganic phosphate to be active. Glycogen phosphorylase needs inorganic phosphate to be active. But since inorganic phosphate is decreased, what will happen? Glycogen phosphorylase is not active. So if glycogen phosphorylase is an enzyme of glycogenolysis, it's an enzyme of glycogenolysis. So if glycogenolysis is not taking place in fasting state, what can happen? There can be hypoglycemia. Is it not? Hypoglycemia. Yes. So immediately after food, your food dietary glucose can act as a can maintain your blood glucose level. But after that, in the fasting state, your liver glycogenolysis maintains your blood glucose level. But for that, the rate limiting step is glycogen phosphorylase. So if your inorganic phosphate is decreased, the glycogen phosphorylase cannot be active. So it is inactive, so leading on to decreased glycogenolysis. So that will lead on to hypoglycemia. Okay, so in galactosemia, there is hypoglycemia due to decreased activity of glycogen phosphorylase. Understood? So this is so what are all the symptoms we have seen as so far? Galactosemia we have seen. Yes, we have seen galactosemia, we have seen cataract and hypophosphatemia and hypoglycemia. Okay, hypoglycemia. Next, this hypophosphatemia in the cells, inside the cells which are undergoing this galactose metabolism, it will be trapped as galactose 1-phosphate. The phosphate is trapped, so there is hypophosphatemia. Now, since there is hypophosphatemia, your ADP is not converted to ATP. So in those cells, the ADP is not converted to ATP because here even you need the phosphate. So since ADP is not converted to ADP is not converted to ATP, ADP gets accumulated inside the cell. So this purines have to be metabolized, is it not? Purines, if it has to be metabolized. So increased purine catabolism can lead on to increased uric acid. Yes, so that is hyperuricemia. Hyperuricemia. There is hyperuricemia even in the galactose metabolism. So since there is increased uric acid in your circulation, now all of your uric acid has to be excreted via your kidneys. Yes, so in your kidneys, there in the DCT of your kidneys, distal convoluted tubules of your kidneys has to excrete all the acids, be it any acid, be it uric acid or lactic acid. So be it any acid, it has to be excreted out through the DCT via H plus ATPase. Okay, so normally all of the lactic acid which is formed will be excreted here. Yes, so if uric acid gets accumulated in your circulation, what happens? The uric acid is more, so it predominantly gets excreted. So your lactic acid in the circulation gets accumulated, leading on to lactic acidosis. Yes, it's leading on to lactic acidosis. There is hyperuricemia since there is increased uric acid in the circulation. Since all of the acids were excreted through the kidney via the same transporter, instead of lactic acid, uric acid gets excreted. So lactic acid gets accumulated in the circulation, which leads on to lactic acidosis. Is it clear? So lactic acidosis is what we've got now. Next, In the liver, what happens? In the liver, so all cells in which the galactose metabolism, all cells which are concerned with galactose metabolism here becomes ATP deficient. Yes, because ADP is not converted to ATP. So it becomes ATP deficient. So if ATP is not there in liver cells, it can lead on to hepatomegaly and jaundice. Okay, liver cells, that can be liver injury, which can lead on to hepatomegaly and jaundice. And also ATP is necessary for secondary active transport. Okay, secondary active transport by which all of the solutes are excreted in the kidney. So kidney excreted consists the tubule. So kidney excretes all of many solutes through the proximal convoluted tubule, which is by a mechanism, by a secondary active transport mechanism, for which ATP is necessary. So here, if ATP is not present, what can happen? All the be it amino acids or phosphates or like water, everything gets excreted out. Okay, it is not reabsorbed. It is not reabsorbed. So what I'm trying to say is, secondary active transport indirectly requires ATP. Since the cells are ATP deficient, the reabsorption of this solutes by secondary active transport becomes, it is reduced. So the solutes, mainly your amino acids, your phosphates or water, are not that properly reabsorbed. So all of which gets excreted. Okay, all of which gets excreted. So you have amino aciduria. Yes, you have amino aciduria. You have phosphaturia. You have polyuria. So excretion of all these can be collectively called as Fanconi syndrome. Can be collectively called as Fanconi syndrome. Okay, so ATP is necessary for reabsorption of the solutes. Now ATP is depleted, so reabsorption of these solutes is reduced. So all of which gets excreted. This is collectively called as Fanconi syndrome. Okay. Now next is, I had told if epimerase enzyme is also deficient, if epimerase enzyme is also deficient, what can happen? UDP glucose conversion to UDP galactose is also damaged. Okay, so UDP glucose to UDP galactose, that is also inhibited. So UDP galactose concentration itself becomes very less in your circulation. But you need galactose for various substances, various compound synthesis, is it not? So if that is not present, what can happen? There can be reduced synthesis of your glycosaminoglycan, especially your keratan sulfate, which needs galactose. Yes, and also your gangliosides. Yes, also your gangliosides or cerebrocytes. Okay, galactose cerebrocytes. So these things need your galactose. These will be incorporated in these compounds. So if all of these are reduced, if gangliosides, cerebrocytes are reduced, what can happen? It can lead on to mental retardation. Okay, brain damage, mental retardation. There is developmental delay. Okay, so also hypotonia. So these are the symptoms which can happen if your galactose itself is deficient. Gangliosides, cerebrocytes are all deficient. So it can lead on to brain damage. Okay. So what are the symptoms we've seen till now? We've seen there is galactosemia. Yes, to summarize, there is galactosemia, excess of galactose coming out to circulation. It can lead to bilateral cataract. Yes, it can lead to bilateral cataract because in both the lens fibers, galactose can get accumulated. The lens fibers well because of dulcitol. And then there is hypophosphatemia. Yes, there is hypophosphatemia. Now, hypophosphatemia, inorganic phosphate is reduced, glycogen phosphorylase activity is reduced. So, glycogenolysis pathway is reduced. There is hypoglycemia. And then there is hyperuricemia because ADP conversion to ATP is reduced. So, ADP gets accumulated. The purine catabolism can lead on to excess uric acid. Also lactic acidosis, because much of uric acid gets excreted in the kidneys, lactic acid gets accumulated in the circulation. And then there is jaundice and hepatomegaly, because the cells are ATP depleted. There is jaundice and hepatomegaly. Also Fanconi syndrome. Yes, also Fanconi syndrome. And then there is mental retardation, developmental delays. Okay, mental retardation leads to developmental delays. And then there is hypotonia. All right, so these are the features of classical galactosemia. Now, in that question, we had discussed what is your diagnosis, what is the biochemical basis of all the features of galactosemia. So these are the symptoms, biochemical basis of various symptoms. So that we've seen about, there is deficiency of galactose 1-phosphate uridyl transferase, and galactosemia is present. Then because of cataract formation, hypophosphatemia, hypoglycemia, hyperuricemia, lactic acidosis, jaundice, hepatomegaly, Fanconi syndrome, and mental retardation, hypotonia. All right. So what is the treatment of galactosemia? Early detection is very important. Okay, so that is why galactosemia is included in the newborn screening panel. So early detection is important so that we can restrain, we can give a galactose-free diet. Okay, so galactose-free diet, if you give, it is the mainstay of treatment here. But once mental retardation is established, then it will not improve. Mental retardation cannot improve. That is why early detection is needed and lactose-free diet can be advised. Now, what is Benedict's test? So, what is Benedict's test? What is the test for detecting galactose in urine? This is, of course, Benedict's test. So any reducing substances will show positive Benedict's test. Okay. So of which reducing sugars will be glucose, lactose, maltose, fructose, everything. So Benedict's test, what is the composition of Benedict's reagent? Copper sulfate, sodium carbonate, and sodium citrate. Now copper sulfate is for donating cupric ions. Okay. And sodium carbonate is to provide alkaline medium for the reaction. Okay. And sodium citrate acts as a stabilizing agent. Okay, it acts as a stabilizing agent. Now, what is the principle of Benedict's test? Now, any reducing sugar forms the enediol form. Okay, any reducing sugar in alkaline medium forms the enediol. Enediol is nothing but the highly reactive form. So, this enediol can combine with the cupric ions, which is donated by the copper sulfate in the reagent, and it can form cuprous. Cuprous ions forms cuprous hydroxide and then to cuprous oxide. Now, the color of the solution is due to the amount of cuprous oxide which is formed. So, the amount of reducing substances which forms the amount of cuprous oxide, which is responsible for the color of the solution. Now, we also call this Benedict's test to be a semi-quantitative test. Yes, we call it as a semi-quantitative test. Why do we call so? Because it gives different colors, and different colors indicates various proportions, different proportions of the concentration of the reducing substance present. So here, consider this blue in color in case there is no reducing sugar. There can be green color, yellow, orange, or brick red precipitate. So if it is green color, then the amount of reducing sugar can be assumed as 0.5 to 1 gram percentage. If it is yellow, then 1 to 1.5 gram percentage. If it is orange red, then it is 1.5 to 2 gram percentage. And if it is brick red, then it represents more than 2 gram percentage of glucose or reducing sugar present in the sample. Understood. So with the help of the color, we'll be able to find out if this much amount of reducing sugar is present. That is why Benedict's test is called as a semi-quantitative test. Now, what are the non-carbohydrate reducing substances? So as I had already told, not just reducing sugar, any substance which can reduce the Benedict's reagent will show positive Benedict's test. Okay, so other than carbohydrates, there are substances like uric acid, homogenesic acid, salicylates, glucuronides of drugs, and vitamin C, which can show positive Benedict's test. Okay, so that is why whenever you get a positive Benedict test, you have to keep this also in mind. So you have to see whether the patient's uric acid level is more, or whether the patient has alkaptonuria, or whether the patient is taking any drugs or vitamin C supplements. So these kind of things also you have to keep it in mind whenever you get a positive Benedict's test. All right. So this discussion ends with this. So we've discussed what all have we discussed? We have discussed about galactose metabolism and galactosemias, all the biochemical features of galactosemias, right? So, and then we have answered what is Benedict's test and what are the non-carbohydrate reducing substances. So we have answered, you can see we have answered this question. That not our diagnosis, biochemical defect, and biochemical test for reducing sugars, non-carbohydrate reducing substances in urine, and treatment. So all of which we have answered. Yes, thank you all. So hope to see you with another video on inborn error of metabolism, right?